Faculty of Rehab Medicine. My name is Dr. Jackie Whittaker, and I'm an assistant here in the Department of Physical Therapy, and I've been tasked with being your host and MC, so apparently I'm going to be entertaining or funny or something like that, which is highly unlikely. Before we start, what I'd like to do is just thank every one of you for coming out to the campus tonight, and then just respectfully acknowledge that we are situated on Treaty 6 territory, traditional lands of First Nation and Métis people. We, as you can see, have a very special evening planned for you. There's going to be a series of 4 short, and I'm told sweet talks, short and sweet talks. So we're going to try to stay on time and to the point. And the talks are going to be on some of the most innovative back pain research that's happening kind of on a global perspective. So there should be some interesting material for you guys to take away tonight. The idea for this evening's lecture came from a long-standing collaboration between our honored guest this evening, Dr. Julie Fritz and her team from the University of Utah, and Dr. Greg Kawchuk, who is in the faculty here at the University of Alberta, and his team. They have worked for many years together on numerous grants and publications, but this is the first time that Dr. Fritz has traveled to the University of Alberta. So we wanted to mark that event with a special occasion, which is this evening, and we did our best to provide some fabulous Alberta autumn winter for her and her team. I noticed that some of you are out running around in our cool weather, so it's beautiful. You missed some of the really colorful leaves by about a week, but there's still some nice stuff out there. And then in addition to the collaboration that Dr. Kawchuk and Dr. Fritz have had for years, one of our speakers this evening, Dr. Eric Perrant, was actually a postdoctoral trainee under Dr. Fritz at the University of Utah as well. So there's some interesting kind of networking that's happened between the two institutions over the year. So with all these connections, the idea was hatched to get spine researchers together and to catch up on each other's work. But they really wanted to do that in a way that brought together everyone in the community that's interested in back pain, whether you're a patient with back pain, you're a clinician that treats people with back pain, you are a researcher that does research on back pain or related areas, or whether you're a student who learns about back pain, or somebody that manages people with back pain. And I'm sure there are other people in the room that have other interests as well. But the idea was very much to open it up to a very large, diverse group of people. So our speakers tonight, in order of appearance, are, as you will probably see listed up there, are Dr. Doug Ross, Dr. Eric Perrant, Dr. Greg Kawchuk, and then Julie Fritz. But before I introduce them, I've got a couple housekeeping tasks. Number 1, the plan is that all 4 speakers are going to speak. Their talks are going to take about an hour. And at the end of that, we'll have a little bit of a panel where there's going to be some questions posed, and that'll go on for about 20 minutes. After that, as you guys all saw when you came in, we've got a little bit of a reception plan for you in the main hallway, and you can mix and mingle and further discuss the topics of the evening. One thing we do ask, though, is if you could refrain bringing any food or refreshments, bottled water is okay, into this room, just so that we can sort of keep any housekeeping tasks to a minimum. If you have to leave at all the auditorium during any of the presentations, if possible, we'd ask you to go up to the back and leave out of the 2 side doors at the back of the auditorium. When you go out, you'll be in a little hallway, and if you follow that hallway that direction, when you come out the doors, you'll find washrooms either way down the hallway. So if you need to leave, if you could do that, that would be great. Last 2 points, very important. Point number 1. Although all of our speakers and guests are very esteemed and learned on the topic of low back pain, they're not clinical practitioners, so they're not currently treating patients. And so when it comes to question period, it might be in your best interest not to ask them specific questions about your clinical care, because you might not get the best advice. And then lastly, if after listening to the speakers tonight you are interested or your interest has been perked with respect to maybe participating in some research, because I suspect they're all going to speak about projects that are currently ongoing, you're going to find that they will talk to you a little bit about how you might be involved in that research, whether you be a patient or a practitioner that's treating low back pain. So, without further ado, am I introducing people, everyone right now, or one at a time? One at a time. Okay, without further ado, I'm going to introduce our first speaker, Dr. Doug Ross, and he is a professor here in the Department of Physical Therapy at the University of Alberta, and he's the director of the Rehabilitation Research Center, which is a research consulting organization here in the as well, but organization here in the faculty at the university. Doug's research focuses on preventing disability in people with musculoskeletal conditions, including individuals with back pain. So Doug's got 10 minutes.
And your timing, right? So thank you for the introduction, Dr. Whittaker, and thank you very much for coming. Looked forward to this, and it's good seeing a lot of familiar faces, some colleagues, and even some old supervisors. One of my old supervisors from when I was a student is here tonight. She taught me everything I know. Can everybody hear me in the back? Is this microphone working? So, so I'm looking forward to presenting some of the research that I've been involved in and hearing from some of my colleagues about the research that's been going on. I've got some bad news and I've got some good news. So I'm going to start with the bad news, then we'll end with the good news. First of all, how many of you have ever experienced back pain? Just raise your hand. Okay, oh yeah, just about everybody. How many of you are experiencing back pain right now? Okay, that's very typical. The stats say that about 85% of us will at one time or another have back pain, and about 30 to 35% at any one time have pain. So you're not alone. Back pain is experienced by nearly everyone. It's a very, very common reason for seeking health care. When I did practice as a physical therapist, it was by far the #1 reason for coming to see me. It's also a leading cause of disability, and this is work disability, sport disability. We think about people like Tiger Woods or LeBron James, very high-level elite athletes, have had difficulty with back pain and are unable to participate in their sport. Also just activities of daily living. It is very problematic. To give you a sense of how problematic, I want to show you some data from the Global Burden of Disease Study. So this is a study that's been going on for decades. The last few years, it's been funded by the Bill and Melinda Gates Foundation. So this study tries to capture the leading medical conditions worldwide. What's the most problematic? What are the leading causes of death? And what are the leading causes of disability? And since 1990, when this study first started, the very top, the #1 leading cause of disability worldwide has been back and neck pain. And as you see there, it's the same in 2005 and the same in 2015. The leading cause of disability in 158 of 195 countries. So I've been researching back pain for 20 years, and when I see these kind of stats, it's very depressing. It kind of brings me down. But I do have hope, and even the authors of that study had hope. In talking about musculoskeletal disorders generally, which includes back pain, they say this: even if cures for back pain are not yet available, the clinical goal of preventing disability is attainable. So we do have reason to hope. One of the reasons why we have such a problem with disability because of back pain is, well, for one thing, it's the way that for decades the medical and healthcare communities have been approaching it. We've been very effective at getting across the message that we should rest, that you should go to bed when you have back pain, that maybe you should get an X-ray or an MRI, have your back examined, and then either have surgery or take a potent painkiller. This has resulted in people worldwide having very pessimistic beliefs about back pain. And for the most part, people think that it requires medical investigation or treatment and rest or protection of the back. And it's no surprise then that if people think that you should rest, that it does lead to disability and people not doing what they typically do. What does the research say about medical investigations? Well, they are important, and in a minority of cases, they're critically important. But I would say for the vast majority of cases of nonspecific back pain, they sometimes cause more harm than good. This is an MRI scan of a spine showing some disc bulging, some degenerative changes, osteophytic lipping, and so on. This was my back. This is my lumbar spine. It's an MRI that was taken 15 years ago in one of Dr. Perron's studies when he was a PhD student. I am one of those lucky people that have never had a day of back pain. I've never been disabled because of back pain. And yet I have degenerative changes. I'm sure if I did a repeat of this, I would have even more than that. Now I've had neck and shoulder and wrist and elbow and knee and hip, and I've had basically every other joint. But I'm one of those people that have never had back pain disability, despite having these kind of findings on my MRI. The research around first line treatment by surgery and pain medication is also not that great. This is the article that is in this month's Scientific American, October 2017. If it's available online, anybody could look this up. The title, one of those jump out title, grab your attention, forget pills and surgery for back pain. The main message is that many physicians are avoiding those things and advocating a simpler approach to treating back pain, exercise. And you can see in the picture here, there's yoga, cycling. This doesn't look like exercise in the bottom corner there. That's more of a meditative practice. More and more, in addition to exercise and the kind of non-medical approaches, we're recognizing the importance of the mind and non-medical factors. We talk a lot about the biopsychosocial model, the importance of biological factors, psychological factors, and social factors in influencing our health. I prefer to think about it as mind, body, and environment. The body is important, the mind is important, and the environment is important. I think of the environment as the people and the places that we hang out with. All of these things, when they're working fine, they do lead to optimal health. For the rest of my presentation, I don't know how much time I have left. Where am I at? I'm going to talk about some studies that we have done here. What's that?
5 minutes.
Okay, good. We'll take 5 more minutes. I'm going to take the next 5 minutes, and I'm going to talk about studies that I've been involved in here in our department, looking at interventions at the level of body, mind, and at the environment. When we talk about mind, body, and environment, it is not, well, we can't forget the body. The body is still really important. And what the research shows, and what research that I've been involved in has found, is that standardized, evidence-based models of care and rehabilitation do reduce disability, specifically work disability. I was involved in a study looking at over 170,000 injured workers, with about 40% of them being back pain. And we looked at some that were involved in care under a standardized care map or model, and those that were not. The model included the 4 things listed here: timely assessment and reassurance when there was no signs of really serious pathology, reassurance that it was okay and that you can stay active. Acute stage pain coping strategies, very important in the early stages to help people cope with their pain and have tools and strategies for moving past that acute pain. Thirdly, I call it Goldilocks functional restoration. So this is ECME. It's also a leading cause of exercise. Function too early, not too late, not too intense, not too light. It's kind of just right? Just like Goldilocks' porridge. Just right exercise, functionally based, and really, really importantly, integrated workplace-based interventions. And this is not like traditional ergonomics, but this is basically when a healthcare provider goes out and collaborates with the various stakeholders that are involved, the employer, the union representative, the insurance or compensation case manager, and they problem solve. They come up with a solution and they look for modified duties. We found that this type of care led to more rapid return to work and more sustainable return to work. So the body is important. The mind is also important. We have found that psychologically informed care can also lead to long-term lasting improvements. We've recently studied something called motivational interviewing as administered, not by psychologists, but by rehabilitation professionals, OTs and KINs. MI is a client-centered counseling approach aimed at resolving ambivalence. Ambivalence is kind of sitting on the fence. You don't know if you should return to activity or not. You don't know if you should go back to work or not. And this typically arises because of conflicting opinions. The goal of MI is to increase an individual's intrinsic motivation to change from within instead of being forced to change from without. And we found that 1 to 2 sessions, and these sessions only take about an hour each, 1 to 2 sessions led to more sustainable return to work up to 1 year later. So the mind is important. Social. The social context of care can also be important. We also did a study here, right here in Corbett Hall in the basement, looking at the influence of therapeutic alliance, effective kind of bedside manners on the part of the healthcare provider. We looked at care provided in an enhanced therapeutic alliance situation and in a very limited therapeutic alliance, where basically instructions were given and a treatment was provided. When the therapist provided care with attentive listening, formed a bond, and really tried to make a connection, it did lead to more effective and clinically important reductions in pain. So the social context of care is important, the social context of what we believe and think, and our broader cultural context is important. For a decade, there's been a mass media campaign going on in Alberta. I'm going to play one of the ads. You may have seen some of these advertisements on buses or posters. I'll play one of these.
Oh, hey there, Margie. You look like you got some back pain there.
Yeah, Bob, I tweaked something yesterday when I was sweeping the ice at the curling tournament.
Shouldn't you be at home resting it then?
Wrong, Bob. Staying active is the best way to reduce back pain. Way to go, Margie. Way to stay active. There are lots of activities that can help you with back pain. Stretching, walking, swimming, and more. Back pain, don't take it lying down. For more information on how to manage back pain, visit backactive.ca. And remember, staying active is better for your back.
So you may have heard that if you listened to the Oilers games, that was played at every intermission last year. We've been evaluating this for 10 years, and we found, I told you at the beginning, 50% of people thought that they should rest. 10 years later, we're up to about 72% agreeing that they should stay active. And if they report having heard that advertisement, it's up to 80% of people agreeing that they should stay active when they have pain. So it is possible to change even cultural beliefs. And I want to go back to this quote, this hopeful quote that even if cures for back pain are not yet available, the clinical goal of preventing disability is attainable. I do think that there are some promising biopsychosocial interventions that have been evaluated here. You're going to hear more from my colleagues. I'm going to end just with some of the collaborators, because research really is a team sport. There's been many grad students, U of A colleagues, and collaborators from elsewhere who have been involved. And there's also been many organizations involved in funding or data collection or just helping out and supporting this research. So thank you very much.
Perfect. No problem. You were not really that far over at all. That's good. Impressive. It's not easy to get researchers to stay on time. I don't know if you guys know this, but when you give them an opportunity to speak, I'll speak for myself, we tend to go on a little bit. So anyhow, that was awesome. That was great. So our second speaker tonight is Dr. Eric Parent. Eric is an associate professor in the Department of Physical Therapy here at the University of Alberta with an adjunct appointment in the Department of Surgery. Dr. Parent's research focuses on the assessment of persons with scoliosis and low back pain with a particular interest in diagnostic imaging and quality of life. And he's also interested in demonstrating the effects of specific exercises for scoliosis and low back pain. And Dr. Parent serves as secretary of the International Society on Scoliosis, Orthopedic and Rehabilitation Treatment.
Thank you. So it's a pleasure to be here tonight to share a little bit of a different focus, more on the scoliosis aspect of back care. We've been at work in recent years showing the effect of scoliosis-specific exercise on pain, self-image, spinal deformity, so far in adolescents, but now turning onto adults with idiopathic scoliosis. So you may not have heard as much about what scoliosis is. So scoliosis is a lateral curvature of the spine that exceeds 10 degrees when measured on an X-ray. It also comes with a 3D deformity. And by 3D deformity, what we mean is the vertebrae are rotated, they're offline in the frontal plane, and their sagittal profile of these patients is also different, either more flat back or more curved back. In order to detect scoliosis, we encourage families to look for the shape of the back of their adolescents around age 10 and again around age 12, trying to see, is there scoliosis appearing in there? And to do that, you would try to follow where the spine is, and a normal spine would be a straight line down. A patient with scoliosis, you would follow the bone and it'd go laterally. So that'd be a first clue. You would also look for, is there a part of the back that's more prominent than the other? You're looking for a rib hump and a lumbar prominence would be another clue. You'd want to see, is the shoulder really laterally shifted relative to the pelvis of the patient, a lateral deviation there? That'd be another clue. And then the waist, normal hourglass shape, or an asymmetry with a flat shape of the waist on one side and a very indented shape on the other side would be another clue. And finally, a hip prominent on the one side or a shoulder asymmetry would be other clues. If you find that, then you might want to go ahead and do what we call the bending test. To do a bending test, what you do is you ask your person to bend forward, and then you look for the back profile, and then you see on this case that there was a prominence in the low back and there was a prominence in the thoracic spine. Well, if you notice that, it's measurable. You can download an app and look at the shape of the spine by looking at the tilt as the patient bends forward. If you hit more than 5-degree deviation, we recommend that you go and seek a radiograph from a doctor to confirm whether there's a scoliosis there and whether care might be indicated or not, okay? How often do we find it? It affects about 2 to 3% of the adolescents, so it's quite common to find some degree of scoliosis. If the scoliosis is less than 20 degrees, we'll just wait and see. We'll watch the patient on a regular interval and make sure that this curve is staying put. If it starts growing, it becomes more severe, more than 20 to 40 degrees, then we will recommend rigid bracing for the patient. The patient will be asked to wear a brace maybe all day long, maybe nighttime, depending on their severity, to try to prevent further progression when they're growing. Or if it becomes really severe, then we will go ahead and offer surgery to try to prevent further progression, prevent consequences of scoliosis in adulthood. It affects, to a degree that is severe enough to require treatment, much more girls than boys. About 10 girls to 1 boy will be affected to a degree that requires treatment. Where do exercise come in this picture? Exercises are not yet recommended in our North American guidelines, despite some promising results in Europe. There's been some positive effect reported on limiting deformity progression, improving quality of life, improving the posture of patients, their muscle endurance, and possibly preventing consequences of scoliosis on respiratory and quality of life in adulthood. So Schrott exercise is one method of exercise that's popular in Europe that hasn't been really thoroughly investigated in quality design, which we decided to focus on. It consists of asking the patients to do some stretches and motor control exercise to try to correct their posture, beginning initially with lying down exercise, progressing to more challenging positions such as sitting, standing, and eventually into dynamic position, maintaining the corrections in walking or in transitioning from standing to sitting or in different other posture. So we chose to test this intervention, and we adapted the dosage, not for full-time camps like it is done in Europe, to a dosage that we believe is feasible in North America. We asked the patients to do 3 exercises daily for at least 30 minutes. We visit with them once a week to adjust their program, and we follow them for 6 months. After that, we believe they're independent. So we also now more recently try to analyze how the exercises are done to really demonstrate that despite that we ask some very complex 3D correction of the posture, the patients can do it. So using 3D ultrasound, we're looking at what can the patient do. The exercise typically begin with, can you correct your pelvis alignment relative to your spine? We typically try to ask the shifting of the spine to midline, and in patient with double curve, that really means we are asking the 2 double shift. We adjust the shoulder position. That's an example in lying down, and we also use breathing to expand the concave area and learn how to correct the posture. That's a lot to think about for an adolescent. But with 3D ultrasound, we've now demonstrated that it is possible to measure that during the exercise, the patients are able to significantly reduce their thoracic curve and significantly reduce their lumbar curve, to the point where all our patients were able to reduce one of their curves by at least 50% during the exercise. So they are able to take in our cues. So now we're determining over a longer period of time, over 6 months, can we add Schrott exercise to the standard of care offer here in North America, which consists of observation of breaks. Let's look what the effects are. So we had in this case a sample of 50 participants randomized between 2 interventions. It's a wide range of curve severity between 10 and 45-degree curves that we involved in the trial. We randomized them either adding Schrott to their therapy, standard care or receive just bracing or observation. We followed them for 6 months, and they practiced their exercises daily at home, and then we saw them once a week. The patients were able to stick with the program. We only lost 6 participants over the 6-month period, which is pretty good for such a trial. And they were able to complete 76%, 73% of what we were asking at home, and the visits that we were asking. So they were able to stick with the program. And as a result, we were able to slow down progression and actually gain a little bit of correction in the patients that received the exercise approach, while the other group continued to deteriorate for a small significant difference. There's a typo here. It was p less than 0.05, and a positive effect on reducing curve progression. The surgeons tend to look at, were you able to limit curve progression in patients where less patients progress by more than 5 degrees. We also showed that this was the case with our patients progressing. We also had a good effect on the improvement of the muscle endurance in these patients. So we asked, how long can you hold your body horizontal? And these patients gained about 30 seconds of endurance over the first 3 months, and they maintained those gains over time. It also translated into improved self-image for these participants in the later part of the trial and improvement in the pain. Pain is not a big problem in scoliosis in adolescents, but when it's there, the exercises are useful to control that pain, is what we demonstrated here. And then we took a number of objective specific posture measurement, and we showed that the waist asymmetry was getting better with exercise, the pelvic alignment was getting better with exercise, the lateral shifting of the torso was getting better, the torso rotation was getting better, and the prominence were getting reduced over time, both in the thoracic spine and in the lumbar spine with the use of exercises. So that led us to conclude that 6 months of short exercise is showing promising outcome, but what we need now is long-term outcome. Really, the treatment for scoliosis has to do until they're done growing. So we are encouraged and continue studying over long-term periods of time now what effects exercise may have in patients with scoliosis. We've now recently also turned our attention to adult scoliosis. So adult scoliosis is still the same deviation, but it affects this time 11% of adults. So it's quite common, and it's been heavily neglected up till now. Some of the scoliosis in adults is really idiopathic scoliosis from adolescent years that didn't go away, and we still observe it in the adults. But we're starting to see now with people living older, with bone health being what it is, that we start seeing degenerative scoliosis appear in our older adults, and that's becoming a more important problem. We did a systematic review of the literature to try to see, well, what's been done on the effect of exercise with adults with scoliosis, and we only found that one study so far. So there's a big gap in terms of work to be done. Again, like with most exercise study in scoliosis, the quality was limited by some important bias, but still, the conclusion at that point was that exercise may be a good solution in this group, where compared to general physiotherapy, there was limited evidence that 20 weeks of exercise significantly improved the pain in these adults, and pain is a more important problem in the adult than it was in the adolescent population. It did improve their quality of life. It did improve disability issues. And so we are now turning our attention to examine the effect of exercise in the adult population going forward. So again, in closing, I would like to acknowledge the funding we've received for that line of research on exercises for scoliosis, and the collaborator that helped us achieve this work over the years. Thank you.
Record time, 10 minutes and 5 seconds. Very impressive. The more esteemed and well-practiced the researcher, the more likely they are to stay on time. So obviously, we're doing pretty well tonight. Okay, so the third speaker in our lineup tonight is Dr. Greg Kawchuk. Greg is a full professor here in the Department of Physical Therapy at the University of Alberta, and he has an adjunct appointment at the University of Southern Denmark. Dr. Kawchuk has been interested in helping people with back pain since his early days as a practicing chiropractor, and he put many, many years ago. Greg's research interest as a PhD in bioengineering. Pardon me?
It's because I look so young.
I know. Well, he is the one, I don't know if I should point this out, but of the four, there is a distinct feature that Dr. Kawchuk has that the others do not have. One of them really doesn't have it, actually. Last thing I want to say is, as Greg's research interests as a PhD and in bioengineering focused on creating better diagnostic and therapeutic tools for clinicians and their patients.
Thank you, Jackie, and thank you everyone for being here. Hold your applause, really. No, and remember to give it later. Before I get any further, it's university policy that I have to warn you that there will be some upsetting images in my talk, and we might as well start with the most upsetting one, that winter is coming, people. And if you're not familiar with this as an Edmontonian, you soon will be. And the best outcome for a problem like this, when you have car trouble, is this, that you get to talk to the mechanic and explain to them what the problem is. When did it start? When did you first notice it? How long has it been going on? But then that should be quickly followed by some measurements about how the car is actually functioning. So we can learn a lot from that in back pain, and that a really good experience with your mechanic is made up of you talking to them about the things you feel and the things you know, but then that 40-point or 99-point inspection that you get that kind of rounds out the whole package. And believe it or not, your spine is very much like your car. Inside, there's lots of really sophisticated mechanics going on, and it's really no different for the sophisticated and really mysterious in some ways mechanics that go on inside the back. But instead of talking to your mechanic about your back, you talk to your healthcare provider and your clinician. And that's a really important point, because you need to tell them how your back pain is interrupting your life, when it started, how it affects you, was there something that maybe triggered it? And those are the kinds of things that we're really good at asking in back pain. In fact, we like to interrogate our patients. We have so many questionnaires for back pain, it's actually kind of staggering. But what about the other part of the equation? What about the testing that should go along after the questioning? Well, as Doug pointed out, some of you probably think the ultimate thing you could probably get for your back pain is an MRI. It's certainly hard to get and it's very expensive, so it must be good. Well, let's go back to that whole idea of the car and say that if you had a car that didn't start, would you take a picture of it and then send it to your mechanic and ask, can you tell me what's wrong with my car? It would almost be impossible just from the picture itself. Perhaps the only thing you could tell is how old the car might be. You couldn't tell if it works, if it starts, how fast it goes, if it's comfortable, nothing about the function. And MRIs are the same way. With these MRIs, the one on your left shows someone with a disc bulge. The one on your right is a textbook normal. But it would be almost impossible to tell if any one of these MRIs belonged to someone with pain. In fact, the person with the disc bulge probably only has about a 30% chance that they've ever had back pain related to anything that you would see on an MRI. In fact, MRIs now are 50% unnecessary, and that's in our own city, a study that was done a little while ago. And there's moves now to decrease MRIs and other unnecessary tests globally. So it's not so much anymore that this picture is worth 1,000 words, it's really that it's just worth $1,000. And for back pain, that's not much for us. Great for stroke, great for a lot of other things, but for back pain, not so good. Well, many of you in the audience know, well, MRI is not the only way that maybe we can do this checkup that we have. We have a lot of other tests as well, a lot. From range of motion to sit standing, whatever you have, we've done it. The issue is that sometimes those tests don't always go along with improvements in your symptoms. So for instance, someone here who's doing a range of motion test, we could see that after treatment, their range of motion gets better, and so does their pain. Fantastic. But we've also seen that their range of motion gets better and nothing happens with their pain or disability. That sometimes the range of motion doesn't change, but their pain gets better. And sometimes nothing changes at all. So that's not a really great kind of test. We want a test that is really truly linked to the symptoms or the problems of the patient. So we've got the subjective part, we've got the mechanic asking questions part, automotive scope tests that I showed you earlier. Well, I'm going to show you some ideas we've had recently that have led to maybe filling that void for those elusive tests. And it all begins with this idea. And that is, we took a bunch of patients with acute nonspecific back pain and we gave them spinal manipulation. Now, you could even put acupuncture or other things into this. This happened to be a very popular intervention that chiropractors, physical therapists, osteopaths, naturopaths, you name it, people do this. And like most of these studies, you'll give this to people and some of them get better and some of them don't. That's pretty typical the way that most of these studies go. Well, if we stopped there and we went back in time by about 10 years, and you asked people, well, why is it that people could get better with this intervention? A lot of skeptics would say that it's because these are the people who just want to please you as a practitioner. They'll tell you anything you want to hear. Of course, it got me better. You're a wonderful practitioner. But it's really these people, the ones who it didn't work for, they're telling the truth. No, it didn't actually work for me. It was not helpful. And without a measurement, if we're just believing you, there's a lot of people who will discount your feelings as a patient. That, well, you don't quite know what you're talking about. This really shouldn't work for anyone. And that's the problem when we rely solely on subjective measurement, asking people what they think. So we thought we could fix this. We could maybe find some measures that would fill this void. And the first study we did with this was in conjunction with our esteemed guest tonight, Julie Fritz. And we did this at the University of Utah. And we thought, why don't we try measuring some things that go along with these studies? And this is actually one measurement that pushes into someone's back and it measures how stiff they are. Something that clinicians and people have done for centuries, poking into eyes, poking into things and going, it feels too stiff or too loose or just right. Kind of the Goldilocks approach as well. Well, in that study, what we showed is the people who said, you know what, I got better after manipulation, they were the green people. Their stiffness plummeted right after they had the treatment. The people who said, you know what, wasn't so good for me, their stiffness didn't change as much. We thought, that's a pretty good finding. But then we were able to follow it up with a student from here, Arnold Wong, who is now a professor at Polytech in Hong Kong. And what he did is he combined a bunch of other things that were missing in the prior study. And what he showed is not only do people who say, I got better after treatment, their stiffness goes back down, but it also goes back down to that blue line, which is what normal asymptomatic people have for back stiffness. And not only that, is if you continue to give them treatment over the week, the people who got better continue to stay better. But interestingly, the people who said, you know what, it didn't work for me, it doesn't matter how much more treatment they have in that week, they continue to be non-responders. It doesn't work for them. We also saw this in a few other measurements. This is a measurement we take with ultrasound to show you how thick someone's muscles get when we give them a lifting task. And this is at rest, and then they bulk up when we ask them to contract, so just go back and forth here for a bit. And what you can see is the same trend, is that the people who say, yeah, I got better, they go up towards the blue people, the asymptomatic people, and they stay that way with treatment. And the people who don't get better, it still doesn't change for them over this week period. And similarly, even this biological measure, how much water flows into the disc, the people who get the treatment and say they improved, they have the biggest changes in their disc hydration, which is a good thing compared to the people who don't. So that kind of changes things a bit. It's not just whether or not you say you got better. Actually, there are measurements that show the people who report being better have at least 3 physical things that change with them that go along with that report of improvement. Where the people on the other side, they don't have that. And that starts to kind of fill out this idea that we maybe have some tests that are linked to patient symptoms that can go along with these surveys and questionnaires we ask all the time. And you know, this kind of explains a lot of things. You know, in the community, whether it's acupuncture, chiropractic manipulation, exercises from a physical therapist, it almost doesn't matter. This is kind of the standard way it goes. Some people tell you it's the best thing that ever happened to me. And other people go through the same type of treatment and they go, you know what, it doesn't work. And there's a lot of people who don't know what to do because they're confused. They don't know whether to believe their coworker or their aunt or whoever it was. But what we now know that maybe from these results, it tells us that if we ran a study right now and we recruited a bunch of people with back pain, depending who was in that study, we might get a positive result. If it was filled with responders, people who are going to get better with treatment X, then we probably get a positive study. But we could take that same methodology, same quality of scientists, and run that again. And if our population is made up more of non-responders, it's going to look like we have a negative study. And that could be why we see a lot of differences sometimes in the literature. About seemingly the same study. And this really changes a lot because think about it. Everybody gets to win. Those people who said, you know what, this stuff doesn't work, or this stuff is the best thing ever, everybody's been right all along. It's a win-win-win situation for everybody. Right? Who would have thought that would have been the outcome out of all this research? Now, the other thing I can tell you is that stiffness, that thing we tested with the probe, is a very unique word in that it has something about it that can create an illusion that I'll show you about in a second. And this is another one of our graduates, Tasha Stanton, who's now gone to be a very prominent researcher in Australia. And Tasha recently came back to Edmonton, to U of A, to do this study that I'll tell you about. No one ever says, my cholesterol feels great today. Like, you just don't have an idea of what your cholesterol level is right now. But we can take blood cholesterol levels and we can know that. Stiffness is kind of unique in that we can measure stiffness, but we can also ask you, how stiff do you think your back is? And that's pretty neat. Like, if, you know, you could say, I've got stomach cramps. They're not really stomach cramps, they're gas distension. So the words here are the same, but you know what? They're not the same thing. If you actually measure people's back stiffness and then ask them about their stiffness, it's not the same thing. So feeling like you have a stiff back and having a stiff back are two completely different things. And this is just researcher stuff to show you that that's the case. I'll pass by it really quickly. So that tells us that they're two different domains. It's like that half of apple and half an orange. You can't swap one for the other. And so then we had, if that's the case, if I ask you how stiff your back is, and it has nothing to do with how much I measure your back stiffness to be, then what is it? What could it be that you're feeling? And what we got is a chance to actually ask that. And we used this called the marble hand illusion. What it is if I tap on your finger, and you hear that sound, that's actually a sound of a hammer hitting a marble tabletop. And it gives the person the impression that their joint is actually stiffer than it is. And what happens is when you ask people about how stiff do you think your finger is, they'll tell you it's much stiffer after hearing this than if they didn't. So we're kind of gaming the system. And we found out we could do the same thing with this test. Listen. When they get their stiffness tested, they actually tell us their back feels less stiff. And their back stiffness hasn't changed at all. But yet if we play them this sound, and I apologize for this. They find they're more protective of their back. They report that their back is stiffer than it should be. So what it could be is that what you think is stiffness, what you would tell me about your back stiffness, could actually be a protective mechanism that is helping you decide whether you should move slowly, move quickly, or all those other things that might go along with this. And this is hot off the press. We've just discovered this. So this could be sort of a two-pronged approach where we could end up changing stiffness through therapy, but also being able to use new treatment options that could target this type of sensory input to change perceptions in the brain. So finally, what about those non-responders, those poor people I showed you earlier who nothing worked for them? Well, we're doing a study right now that Dr. Fritz is going to tell you about that's looking into how do we best handle when manipulation or treatment X doesn't work for someone. And you've been invited here for a reason, because study that would look into this question. I have some information for you here that you can come and participate. And everyone who's involved in the study, would you put your hand up? There's lots of people here in the room you can talk to as well and be able to find out more information about this. So I hope this talk and the other ones tonight have opened some new doors for you and started to make you think about some new ideas in back pain and how to treat it. And with the other speakers, I'd like to thank the people and the agencies who've supported our work now and in times past. So thank you for this evening.
All right, perfect. So we come to the the best part of the evening. No, I thought that was all great so far. But finally, our honored guest and featured speaker tonight is Dr. Julie Fritz. Dr. Fritz is a distinguished professor at the Department of Physical Therapy and Athletic Training and the Associate Dean for Research in the College of Health at the University of Utah. Her research is focused on clinical decision-making and treatment effectiveness studies related to individuals with low back pain and other musculoskeletal conditions. And her research has been funded by numerous agencies, including the National Institute of Health and the Department of Defense in the United States.
Thanks, thanks, Jackie, and thank you. Thank you all for coming out tonight. And as Jackie mentioned when she began, my career has been such that I keep intersecting with people who are here in Alberta. So this is the second time I've been to Edmonton, but the first time I've been to the university. It's really a pleasure to be here. As Greg gave a very nice pitch for the study that we're doing, which is the excuse to be here, and I'll tell you a little bit more about some of the details about that. So, and Greg really teed this up very nicely in terms of my perspective in studying manipulation. So I'm a physical therapist. I've been a researcher almost my entire career, but this treatment has always been fascinating to me. For the reason that Greg talked about, that in talking to clinicians and in observing patients, you would see this differential effect that had that could run the gamut from this is the best thing that ever happened to me to I'm worse. And as a researcher, trying to unpack that has been really fascinating. So manipulation has been around for a long time, which means, there, in my interpretation, there has to be something there, or it wouldn't have existed since time immemorial. But it's been explained a lot of different ways, which kind of also tells us that nobody really knows exactly what the magic ingredient is here, because people have come up with all kinds of theories to explain why is it that we observe that phenomenon. Now, a little bit of backdrop in terms of, from a research perspective, and Greg teed this up nicely in talking about the nature of the way we do research with this and what we tend to find. So in the United States, there was a couple of fairly consequential papers published recently. So in the Journal of our American Medical Association, there was a large systematic review that just came out a couple months ago that basically said what Greg so nicely pictured, which is there's been a lot of studies on this, and, you know, manipulation's not too bad on the whole, on the aggregate, lots of studies, lots of patients. You see this word modest all the time. It's a modest effect. We had also in the United States, our American College of Physicians recently updated a clinical practice guideline related to back pain. And you can see it's kind of a wishy-washy recommendation, like, it might help. And again, low quality evidence for modest effects. Interestingly, along with the systematic review, a rather influential thinker and researcher on back pain, Rick Deo, did a commentary. And there's a lot of interesting things that Rick had to say in there, but a few that I think really inform what we're talking about tonight is that the basic takeaway for him as a researcher, as a practicing physician is, you know what, manipulation doesn't seem to be any worse than anything else we do for back pain, so why not do it? Because it's kind of cheap and, you know, doesn't really come with side effects that a lot of medications come with. So again, it's not exactly a ringing endorsement, but you know, physicians ought to consider recommending this. They probably ought to do it more than they do recommend it. And he's particularly talking about this in the light of what in the US has really reached a crisis, which is overprescribing pain medications, particularly opioid pain medications. So if these things are kind of like 6 of one, half a dozen of the other, then this seems like a better option. And interestingly, one of the things he stated in there is that he's talking to physicians. One of the reasons why there may be some hesitation to recommend manipulation more often is nobody knows why it works. And for those of us who come from a science background, that's a little disquieting to just say, you know what, it seems to work for some, so why not give it a shot? That we feel like we ought to be able to do better than that if this is like a treatment I'm going to recommend to my patients. A little bit more in terms of what guidelines say. I've looked for a couple of Canadian-related and specifically Alberta. And if you can see, you know, these different guidelines, in general, you get that same kind of lukewarm endorsement. But interestingly, if you look at the two bottom studies that I noted, these are Cochrane systematic reviews. And the Cochrane reviews, as many of you may know, they're not really trying to tell clinicians what to do in the sense of a guideline. It's just a very standardized review of the literature. And they basically say, this doesn't work any better than anything else, so why recommend it? So the picture here is that it seems to kind of work, maybe, sort of, but very small effects. And that's been the case since I've been researching this, and trying to figure out how we might be able to do better has been one of the things that I've always found very fascinating, and I wish I had a few answers for you, but it's kept me going for about 25 years trying to figure this out. So how could we improve the effect sizes for spinal manipulation? So either we just sort of accept, you know what, that is about the best we can do, give it a try for folks, and some people will respond, that's great. But this is not an exhaustive list, but there's ways to understand the treatment better that may make it a more powerful treatment. And really, the focus for the study that I'm here to talk about is on that last bullet point. What else are we doing with spinal manipulation that may make it more effective, that may synergize with the effects of manipulation to make it a better treatment? Maybe better, particularly for certain types of patients. And to understand that, what we might try, it really comes back to the roadblock there is, well, why is manipulation working? Because if we knew why, then we could probably design something else to enhance that effect and we'd have a better treatment. So that really comes back to the why question of what exactly is going on. And, you know, there's been a lot of theories, which, again, tells you that none of them are really very accurate about what does manipulation do. And if you're trained in spinal manipulation as a chiropractor, as a physical therapist, you probably learned a very mechanically oriented perspective to think about manipulation. And this particular diagram is just basically saying a joint is stiff, you move it, it becomes less stiff, and that's why people get better. And by and large, there's probably some truth to that, but it's gotten a lot more complicated with more recent research. So this is a diagram that is rather complex, but there's a couple more things that come up in this particular pathway that we're starting to understand are also important. So if you can kind of follow this a bit, you start still obviously with a mechanical stimulus, the manipulation itself, that has an effect on the tissues that you're targeting. And that's where we tended to stop in terms of our thinking, in terms of what produces the effect. But what this model really points out is that other things that we know are involved in some way are the nervous system and the brain. And for my simple way of thinking, this is an easier way to conceptualize it, that there's a mechanical input, it has a mechanical effect, it triggers a neurophysiologic effect, and then the brain is involved, and there's all kinds of complexity that goes on there in terms of some of the things that Greg was beginning to touch on about the way we think about our symptoms, things we used to label kind of pejoratively as a placebo effect, the way that patients' attitudes and beliefs, things like fear, things like the tendency to catastrophize pain affect clinical outcome. So we now understand there's some, and I'm sure there's missing components here, that in some way these things come together, that some patients get a really nice clinical effect and others it doesn't seem to impact them. So Greg mentioned this study as the first time that he and I teamed up, and Greg's been a wonderful colleague to work with on this kind of research, because I am not a car mechanic. I am not a mechanic at all. I don't think mechanically, I don't think like an engineer. I think I think like a clinician. So my perspective is if somebody's getting better, then in a way, I'm not really sure about looking under the hood and trying to figure out why. I'm just glad they're better, which is a much more clinical perspective. So I need colleagues like Greg to help me understand what's going on under the hood. And that was really what we were beginning to investigate here. I won't bore you with the details because Greg's really gone through that. But as he nicely showed you, what we did in this study was just do a 1-week protocol, manipulated people a couple of times, and take a fairly rigorous amount of measurement before and after each manipulation, focus particularly on this measure of stiffness and muscle activation, as he showed, and basically try to identify what's different in people who respond at a week and people who don't respond. And as he mentioned, we found some interesting things, and I'll just kind of cut to the chase here. This is the model that we came out with at the end of that, that's moved us forward in terms of our thinking about this. So don't worry that much about the numbers here, but that basically this mechanical event clearly has an immediate effect on people's stiffness that relates to their clinical outcome. And then it also seems to have an immediate and sustained effect on their muscle recruitment. And all of this tends to predict the clinical improvement. Not real robustly. There's clearly some things missing from our model, but it at least gave us some factors to concentrate on to move forward on. So, and I don't know when we did that study. It's been 6 or 7 years now. And so Greg and I had several failed attempts at trying to figure out where do we go next? In terms of, or at least I should say, I had several failed attempts. He did some nice work with Arnold and a few other studies. But really looking at what is the next logical step here? Because that previous study that we did, not a very clinical protocol. We just followed people for a week. It was a very immediate effect. This particular call came along from the NIH in the United States that really seemed to fit what he and I had wanted to do, because it was focused on this word of optimize. How do you optimize a treatment? So we felt like, okay, we've got spinal manipulative therapy. It's a nice treatment. It seems to help some people. How do we optimize it? And that's really what this call was about. And we thought we had a good chance to move that forward. So we put together a team here at the University of Alberta, as well as the University of Utah. We're recruiting subjects in both places. And the question was, how do we optimize? That's what this particular opportunity asked us to do. So we recognize that most behavioral interventions, which is one way to think about any kind of multiple components. So one of the problems with a lot of research that most clinicians wouldn't provide spinal manipulation in a vacuum from other treatments, but that's often the way we study it. So if we think about how do we actually deliver spinal manipulation to make it most effective, there's all kinds of components to consider. What's the dose? What type of technique? What's the mode of delivery? And what are the co-interventions that go along with it? Well, if you think about, as a researcher, the typical approach to trying to figure out how do we make a better treatment is to package these components together. Basically, take your best guess and do a randomized trial and see what happens. So, it kind of looks like this. We know, there's all these different components, moving parts that we could use to optimize manipulation. We package them together into a black box, and then we do a randomized trial against some comparator. And, if the study is significant, the black box works. That's really nice, but what components really contribute to the overall effect? You can't really know unless you've got so much statistical power that you can do all kinds of post hoc tests. Do the components synergize each other? Again, it's really hard to tell. And then what if you get no significant effect or not anything terribly exciting? You're not sure where to move forward. Which components are worth retaining? Are they all unnecessary? Should you just start over? So we did not want to take this package things together and give it your best shot approach. So we decided to go a different route with this and used a theory that I hadn't been familiar with but seemed like the way to go. And I'm sure it's much more complicated than I understand it to be, but it's basically the idea of avoiding this treatment package approach and conduct a study where the goal is not necessarily to test the treatment, but to optimize it. And to be clear about what the construct is around which you're optimizing and to clearly define your components. Okay, so this is sometimes called a multi-phase optimization strategy, or MOST is the acronym. So here's kind of how it looks in my simple mind. You have all these components, you define them, and you define how you're going to optimize them. What's the outcome around which you're going to optimize this? For back pain, it's usually pain and function. And then you create an optimized treatment package that you'll then test against a comparator so that you think you're not just guessing, but you actually have a box of treatment that you think is your best foot forward. So the step that Greg and I are working on right now is this preparation phase and moving forward towards the eventual RCT, but instead of jumping right to it, really trying to understand components. So let me just explain what this looks like specifically in this project. So there's dose, right? How much should we stop at a week if a person's not a non-responder in our previous studies, or should we keep going because they're likely to convert to a responder? We don't know. So that's the question. What about combining it with exercise? So if we think spinal stiffness is a pathway by which some people get better, then what exercises would work on that same pathway? That's a component. Same thing for muscle activation, specifically the multifidus. If that's a pathway, how do we accentuate that pathway with exercise? What about this phenomenon of the person who responds rapidly and early? Once again, should we stop? Do we actually run the risk of making them worse if we keep going? If we do keep going, should we keep manipulating them, or should we switch to exercise? If so, what exercise? That's another component of defining our treatment protocol. And then there's a patient's clinical characteristics, and this is based on some of my background work of looking at measure on the patient and how spinal manipulation. How does that personalize treatment? So these are the things that we're studying to figure out how to optimize the treatment. And then hopefully we'll have a nice package, another study to do that looks more like a traditional randomized trial. Okay. So a little bit of researchy stuff. Actually, this may work better with just a picture. So this is a complicated study. It's a heck of a lot easier to do the treatment package approach where you say, get a bunch of people, randomize them to A or B, and run the study. But we wanted to, again, our goal was this optimization question, not a treatment effectiveness question. So here's the way this study works, is basically we think of it in phases. So we do essentially a repeat of the study that we had done previously over a week. 2 sessions of manipulation, only manipulation, pre and post measurements, reassess people at a week, see if they're a responder or not. Responder, by the way, we throw that word around. When we talk about a responder, we're talking about somebody who's really better. Like, you know, it's 50% decrease in their disability, which if you use the oswestry a lot, like, that doesn't happen a lot. That's somebody who's better. And then we randomly assign people using a factorial design to a phase 2 treatment. So factorial designs, I won't get too researchy on you, but for those of you who kind of understand this, is a really great and more efficient design for testing these different components. So you can see it comes down to 8 additional treatments. So everybody gets randomized to do something more, or there's also a group that doesn't do anything more. And that allows us to look to see, you know, should we just stop in somebody who's a responder? It gives us a comparison group for non-responders relative to doing something more. And then we wanted to extend out the assessment beyond the treatment phase. So we go out to 3 months to see about sustained effects. Greg nicely showed you a little bit more about our measurements, so I won't repeat what he already showed you. We're not using the little, with the really nice sound effect. I wish we'd have had that. That would have been great. We're using a different and what feels to me like a much more sophisticated stiffness measurement device that Greg's helping us with. I won't get into too much in terms of the treatment, but we have a protocol for how we deliver the manipulation. Some of our previous work has shown that the actual technique doesn't matter that much. So we allow a couple of different techniques, but we try to standardize it so that clinicians are not just doing anything based on their own personal preference. For spine mobilizing exercise, we basically patterned our exercise protocol off of McKenzie because it's that repeated movement to end range seemed like the best exercise approach to say we're trying to reduce stiffness, to make the spine more mobile. So that idea of continually moving more further into the range seemed very consistent with that. For our multifidus exercises, we used a lot of work coming out of Australia to define those exercises. And then the ultimate goal here is to see, again, how do these factors predict particularly the patient-centered outcomes? Because that's the key thing, is to optimize the improvement in function, the improvement in pain. So I'll go ahead and stop there so we have time for a couple of questions. But thank you again for the nice hospitality here in Alberta. And thanks to Greg for setting this up.
Can't go too far because now that you've come and now that you've presented here, we have a couple little gifts, but before we give you the gifts, there's a more important piece, which is everybody that comes here, we're famous for our fleece vests and our fleece coats, and we didn't have any fleece vests, but we have a much more posh jacket for you that you need to put on prior to answering questions because it will help you to answer the questions.
Thank you so much.
No worries. And you want me to save the rest for later? Oh, she can have the rest now too. The rest is more swag from the faculty. You'll stay hydrated, you'll stay warm because you never know how cold it's going to be in the next 24 hours because it could snow tonight. In fact, it may snow tonight. So that's,
Thank you.
no worries, that's great. Okay. So I think we'll have you guys come on up. And are we planning on handing a mic or we're going to throw the mics around? Can we? Yeah. Okay. So we have these interesting toys in the faculty, and they are mics embedded in boxes that are basically like Nerf boxes, and we can throw them to you. And then when you ask your question, you'll speak into the mic, and then everyone in the room will hear what you're going to ask. So we'll open the floor to a few questions. And like I said, one of the things that we're going to try to avoid, if possible, is people asking questions about specifically their back pain or a specific health condition. I know sometimes it gets to be a little bit of a gray area when it comes to that, but without knowing what's going on with your body and without these guys, being practicing clinicians, it's difficult to answer those questions. But the rest of it is open for whatever you would like to ask. So is there anybody who's got a question that would like to start the evening? Blair, perfect. Okay, I'm going to throw. Can you catch? Oh, I'm going to throw not very far, clearly.
I guess, first of all, Dr. Fritz, thanks for coming. How important is the cavitation? Is that a critical part of the manipulation? Like I noticed you said in your study that the therapist will note if they have a cavitation. So let's start there. And then there's lots to go.
That's a good question. We've done a couple of studies where we've looked at that issue of the cavitation or the sound and tried to see if it relates at all to patients' outcomes, which I presumed it would, if no other reason than patients have a sense like that's what's supposed to happen, so that there might be some non-specific effects to that. But we were never able to relate in any of the studies we looked at, either in the thoracic spine or the lumbar spine. It doesn't seem to really relate to clinical outcomes, but we keep it in the protocol just because it's the protocol we've used in a lot of other studies, and it gives us at least a standard by which to define the parameters of the treatment. So it's a really astute point that you pick that up, that I don't think it really matters, but it's still oftentimes both the therapist and the patient perceive that the treatment is done when that happens, so we've continued to use it.
Okay, so if there's a cavitation or no cavitation, what's the explanation of why there's less stiffness after the manipulation?
You mean on the part of our patients, or how we talk to the patients, or?
No, during your testing with your machine, and you have less stiffness.
Right. I just think the noise is unrelated to that phenomenon.
No, I'm talking about if you have a manipulation and then less stiffness, why is there less stiffness? Like, do you think it's multifidus relaxing? Do you think it's the joint capsule loosening? What can we tell our patients when this happens?
Yeah,
and
it's
they feel better.
Excellent question. I think we're starting to find out a little bit what that might be, because we've done a secondary analysis of the people who didn't respond, and we hadn't recruited the number of subjects we need to look at this specifically. It's sort of an after the fact, and we can't put too much faith in it, but it looks like the people who weren't responding in our study had more facet or posterior joint degeneration.
Okay.
So you'd sort of expect that they wouldn't be capable to respond too quickly. So it kind of is the reverse way of answering it, in that what could change that could be that rapid, that would be responsible for the responders compared to these people with maybe more degeneration? So I think it has to be driven neurologically in some way, something related to at least some process that can change rapidly. And I think that's about the best I can put it without having data at this point.
So you don't really know? Like, there's no real explanation at this point that I can...
Yeah, we have another study where we actually injected people with a solution that was either normal saline or excessive amount of salt in it. So it was an irritant. And what we found out is when we injected the irritant, it actually caused more stiffness in the back than we injected just the plain saline. So there is some aspect of pain that is creating more stiffness. And if you can remove that pain, that seems to be what's driving the whole system. So what removes the pain? I don't know. But it seems to be that's the pathway that we're shooting towards.
It's more of a neurological effect, you think, then?
For something to happen that rapidly,
Okay.
it almost has to be, yeah.
Okay.
Now, the head of our department did this the other day and took out someone's laptop. So be careful.
So yeah, thank you for that. That was really useful, especially the objective measurement of the stiffness. You had a really lovely, beautiful, complicated machine to do that objective measurement. Have you figured out anything that is sort of shorthand that the clinician would have access to a tool that could measure it? Yeah, just for practicing clinicians who don't have access to that type of machinery.
You know, we've looked at just a PA assessment mimicking that, and the reliability, if you sort of use the machine as the gold standard, is it's better if you just limit the choices to, is it stiff or not? You know, and some manual therapy schools will give you all kinds of gradations, and there's just no ability to be accurate in that. But if you limit it to, is it stiff or not stiff, clinicians can be moderately reliable against the machine with just a PA. But I'm not, Greg may, or one of the other speakers may know a little bit more about, there's some different handheld devices and things, and I'm not sure about their clinical accuracy.
Yeah, they're not good. Okay. They're not good. I can hold a device very rigidly and game the measurement, and if I hold it loose, it's a different story. So having something that's stationary and takes the measurement seems to give us the reliability that gets the results that you see here. But having said that, we've done a recent study where we showed that the physiological threshold, I mean, you can feel a lot. You can feel a pillow that's too hard and too soft, but at some point that starts to end, and there's only so much you can feel with your fingers. And it turns out the level of the stiffness that we've seen changed is about at the limit of what you can feel with your fingers. So we think, just like clinicians use stethoscopes to improve their hearing, or glasses to improve their vision, or even a thermometer to better assess temperature instead of, your hand, there may be a stage where there's things that we can unveil in the back if we use instrumentation, than to having to say, well, it has to be convenient with my hands or it's a no-go. So we might be crossing that threshold into using more instrumentation in our practices, but maybe on a referred basis rather than in everyone's practice.
Thank you very much. I actually have a question. Can MRI see the stiffness or not?
Can MRI see what?
The stiffness, or?
No, I mean it.
Yeah, indirectly, so we were not measuring stiffness, but we have recently completed a study where we were putting patients under traction and compression compared to the natural lying down on your back position, and to look at what happens to the spine under these conditions. So It's a question of displacement under a standard load, which was set at 50% of the patient's body weight. It did demonstrate changes that were more closely related to the patient's pain when we were under load than we just did the supine MRI. So we're in the process of getting these results ready for publications. It's not stiffness per se, because we're not necessarily looking at a force displacement or really quantifying stiffness per se.
Okay.
There is a relationship between applying load during imaging. Whether that would ever translate into clinical practice, I am suspicious of that, because now we're asking to do 2 MRI, we're asking to put loads, and when we're still in a context where with low back pain, what our goal is at the moment is reduce the number of expensive imaging. This might help us research some processes, but I don't think it will be answering clinical questions soon.
And I was curious also about the optimization method you perform. Is it something like machine learning or?
No, well, there probably could be an application there, but it's really more just taking an intermediary step in a research progression and looking at how components work together or interact with each other before putting them together in a package and testing it against a comparator. So it's really more, I think the key distinction would be that intermediary step where you conduct a study, and it usually uses a factorial design, where your goal is to create the intervention instead of going straight to the intervention package.
Thank you guys for the presentation. Just a question about the assessment of stiffness. So my understanding, stiffness is assessed while the patient in a prone position. So I'm wondering if that is helpful to judge if that person is going to be symptomatic or asymptomatic responder or non-responder in a functional position, as long as we are testing that the spine and the stiffness in non-functional position.
As someone who's not very mechanical with this, I'm trying to envision what that would look like. I'm sure there's a creative way that an engineer could figure out how to do that measure. I think conceptually, kind of like what Eric was saying about taking a static image versus an image under load, that an image under load begins to recreate more realistic circumstances, so it tends to be better representative of the patient's likely pain. But I'm not sure what that would look like.
I'd ask Doug this question, because I think it's the difference between testing someone in a standard position in a clinic versus looking at them in their work environment. And I think from the stiffness perspective, we're doing something pretty artificial right now and have yet to get to that stage where we might be able to test these things in more functional circumstances. So Doug, what are the differences between the exams in those two different situations?
Well, I don't know about the mechanical factors, but it's a great question. And when I was practicing, quite often I would have patients that told me that the MRI even was done with them laying down, and they don't have pain when they're lying down. They only have pain when they stand up with the compressive load. So I understand your question, and I understand where you're coming from. And if you could possibly come up with a way of doing it, sure, it would be a more realistic and a functional measure. But how do you test stiffness during functional ability? I don't know. That's okay, a little bit further in the future.
Yeah, hopefully. So is it more realistic at this stage to ask if the patients are responders in prone position and just limit the conclusion to that position instead of judging the whole population as responders and non-responders based on that position in general? So is it more realistic just to generalize the results on this position, just being responders or non-responders in prone position, as long as we are measuring the outcomes in that position?
Yeah, I may be misunderstanding your question a bit, but the judgment of being a responder is based on an overall functional perspective of doing daily activities. So that's why we wait a week or 4 weeks or such to judge, so the patient can go out and do their daily activities and judge whether they're
less disabled than they were before. So it's the responder status is not based on something that's assessed when they're prone.
Okay, so the last question is how to separate the interdependency between different body parts while doing the assessment in prone position and measuring the stiffness. Thinking about, I'm a physical therapist thinking about fascia and other tissues. How would you judge that the stiffness is due to a back problem and not due to any other places, like maybe shoulder or?
Yeah, we're following that a bit, and I think Eric and Doug could probably add with what they're doing as well, but we're doing simulated stiffness tests in open MRIs now to see what are the tissues that contribute to that overall measure. And maybe that helps answer which are the tissues that are responding the most when we see these rapid changes after treatment.
I think we have time for at least one more question. So why don't we go back there, and then if we've got extra time, sorry.
That's a big throw there. Big throw there.
Big throw.
Big throw.
Oh, no. No. There you go.
Hi. I have one question. Is there any relation between getting pregnant and lower back pain? Also, is there any relation between giving birth to a baby and lower back pain? Because my friend gave birth to a baby last year. After that, she got a back pain, lower back pain, and also in this situation, is there any way to relieve the back pain? Thank you.
So as I understand your question, it's pregnancy?
Yeah,
is pregnancy a cause of back pain? Is there any way to relieve it?
Pregnancy and giving birth to a baby.
Giving birth to a baby.
Yeah.
Yeah, actually giving birth to a baby is a good way to cure your back pain because the mechanical...
Said by a man. Sorry.
No, it's true.
Throw that in.
This is very true because it is the case that when you're pregnant, there's mechanical factors, there's hormonal factors and physiological factors that do make you more at risk of back pain. It's very common for pregnant women to have back pain, and quite often it's been demonstrated that as soon as they give birth, the pain goes away within weeks. So the question is, how do you get rid of the pain when you are pregnant? Well, I would say you go to a healthcare provider and they can give you advice to how to treat that mechanically, positionally, and otherwise. There's some exercises that you could do as well. But
actually, sorry, the truth is that she didn't get back pain when she was pregnant. Actually, she got a back pain after she gave birth to a baby.
Afterwards, so the pain came on after they gave birth.
Yeah,
Right.
That's true.
Yeah, it's more complicated.
So is there any way to relieve the pain, and what caused the pain?
It's hard to say without knowing the details of the individual patient.
Would all the clinicians in the audience put their hands up?
Yeah, go see some of these people.
You could maybe help this young lady here with that question in the reception afterwards. I think that's probably more appropriate than us struggling with that.
Okay.
I agree. Okay, so we can do one last question. But I'm sorry, I'm going to give it to him just because he hasn't asked. But then if you want to come chat afterwards. Good job. Yeah, special.
I'm very interested in the biopsychosocial model. I was thinking, do you think, Doc, that there could be a way that you could see a similar thing to the responders and non-responders in like receiving, the social part where you have the clinician interacting with the patient instead of just telling them what we do and then do it? Do you think there could be a responder, non-responder thing in that part? Like patients being more interested in conversation and actually benefit from it?
Yeah, that's a very good question. And in fact, that's an entire 1-hour talk on its own. But there definitely are non-specific factors that lead people to respond or not respond. In the case there, we were seeing people responding to even an inert intervention. It was a machine, an interferential unit that wasn't even plugged in, but they responded when the other factors were were possible or were positive. We also know with recent research around open label placebos that you can even get a treatment effect when you tell people that there's no specific active ingredient in a medication, as long as the nonspecific and the therapeutic relationship and the nonspecific factors are in play. One huge component of it, this was like a worldwide phenomenon that was in all the newspapers and things, the open label placebo study. In that study, there was a 15-minute session with a physician where the physician listened and spent a great deal of time. So there's certainly some things related to the social environment of the care provision and the mind, the psychological interpretation of what happens that either lead people to respond or not respond.
Just maybe one thing to finish before Jackie wraps it up, and that is if you're interested in any of this and you want to get involved, certainly if you're someone who might meet the inclusion criteria of the study, we have 240 people to recruit between the two sites. So it's quite a big study, and it takes quite a bit of time. It's a 3-month involvement with 8 different sessions. So there may not be too many people here could do that tonight, but if you're a clinician and you want to help advance the ideas of what you do in practice and give your patients a better understanding, I think this is a great study that you can feel confident in that. So come and talk to us. We would love if you each just sent one patient to us in the next year. That would really help the efforts. We're doing quite well right now, but help us recruit, and I think you'll like what you see in the results. Something's going to be helpful, I would think, Julie. If you've seen some things here, I think that you'll see more of the same. So thank you.
Perfect. Okay, well, I would like to thank, first of all, everybody here that's come out tonight. I know sometimes it's not that easy to make your way out. Luckily, it didn't snow. We've got good weather, so it was easy to do. And then obviously, like to thank the 4 of you people for speaking, in particular, Julie, for coming up and visiting us and sharing your wisdom with us. And as I said, there are some refreshments out in the main lobby, so feel free to go out there and mingle, and I think some of the speakers will be around. And if you are interested in research, or if you're a clinician that might be able to recruit a patient or 2, you might want to come grab a flyer, and it'll just give you a little bit more information, as well as some contact information. Okay? So thank you, everybody, for coming out.